This is Urban Health Today. I'm Tamara Thomas, editor-in-chief of Urban Health Today, and I'm speaking with Dr. Terra Wonsettler, Vice President of Clinical Evidence, Policy, and Oncology Pharmacy at Evolent. She's here to talk about cardiotoxicity among cancer drugs and the accelerated cancer drug approval process. Thanks for speaking with me today, Dr. Wonsettler.
Absolutely, Tamara. It's a pleasure to be with you.
It's so nice to have you. All right, let's dive in. Please talk about your background and your work with Evolent.
Awesome. Let's see, I'm quickly nearing 20 years in healthcare. Started as a hospital pharmacist, really focusing in oncology. And what that gave was a really valuable perspective on the opportunity to improve patient care, especially in those specialty diseases. From there, I served 10 years at a health plan, really focusing in on medical and pharmacy benefits. And during this decade of experience, that gave me the line of sight to see that depth of expertise is critical for managing specialty disease. And then today at Evolent, where we're dedicated to connecting specialty care, I serve as the Vice President of Clinical Evidence, Policy, and Oncology Pharmacy. And in this role, my team and I partner with Evolent's physicians to synthesize the latest evidence through our scientific advisory boards and our policies, ultimately delivering best-in-class evidence-based medicine guidance. And additionally, we also drive initiatives beyond utilization management through things like our Oncology Evidence Collaborative, which really partners with our provider practices in value-based initiatives.
What is cardiotoxicity and why is it a concern for cancer patients undergoing treatment?
Sure. So when we think about cardiotoxicity, that's a bit of a mouthful, but we can simply think about it as heart damage. That can arise from certain cancer treatments, during that treatment, or even unfortunately years after treatment, that leads to various heart issues. Some of those issues are things like cardiomyopathy, and that's just a condition that it makes it harder for our hearts to pump blood. Some of those other conditions can be heart failure, coronary artery disease, and arrhythmias. So clearly that's a concern that we want to keep our hearts healthy. So from the cardiovascular perspective, but also from the patient's cancer treatment lens, it can sometimes lead to a pause or even stopping cancer treatment, which is not what we want to do because we do not want to reduce the effectiveness of that cancer treatment either.
How did you become interested in cardiotoxicity and cancer treatments?
You know, cancer and cardiovascular disease, they're two of the most prevalent diseases in our developed world. When I look at heart disease and cancer, they're two of the leading causes of both morbidity and mortality worldwide, and do believe they're accounting for nearly 70% of the medical reasons of mortality across the globe. So when we look across the evidence, those statistics really certainly get your attention and get you very interested in oncology as well as cardiology. As far as that's how they got on my radar. And then the experiences that I had in hospital and managed care really helped me personally realize there's a great need for the delivery of focused, high-value medicine, which is exactly what we strive to do at Evolent. We've got the opportunity to connect specialty care by supporting the management of both of these diseases, cardiology as well as oncology.
How widespread is cardiotoxicity among cancer patients? Are there certain types of cancers or specific treatments where you see it more frequently?
There are. When we step back and look at the studies, they indicate that cardiotoxicity can affect up to almost 40% of cancer patients undergoing treatment. So that certainly grabs our attention when we look at statistics like that. However, the severity of that does vary, which I suppose when we look at 40%, thankfully it's just a few percentages I do believe around three that are experiencing severe symptoms. Of course, that's never acceptable. We want to drive that down to zero. And some of those symptoms that those patients are experiencing, if it's heart failure, patients are going to feel short of breath. They're going to feel that higher heart rate and say, hey, something's not feeling right. I can actually feel my heart rate going up. That makes you more tired. So fatigue sets in as a side effect. Weakness, when your heart is pumping harder like that, you feel weaker overall because your heart's working so hard. And then sometimes weight gain because of those additional fluids. If your heart isn't pumping as strong as it should be, it is challenging to get rid of some of that excess fluid. So that can lead to weight gain as well. So those are some of the things that patients are experiencing. Thankfully, it is isolated generally to certain types of cancers because it impacts certain drugs. So I can talk through some of those higher level, just maybe that they'll stick in
Please.
some folks' minds, but a certain category of drugs called anthracyclines. So very simply, those are chemotherapy drugs. They're really widely used, however, have potential to cause heart damage, especially at higher total doses is when we really, really watch for them. Interestingly, these drugs originated nearly 75 years ago, gosh, back in the 50s. Um, but if they're good medicine, they still treat nearly 30% of breast cancers today. So there's older drugs on the market that do a nice job at treating cancers like breast cancers. But unfortunately, even newer therapies, some things come to mind like HER2 targeted therapies. These can significantly impact heart function, particularly when they're combined with those older anthracyclines. Also, in this newer bucket, the second one I'll mention is immunotherapies. They can cause things like myocarditis, which is just inflammation of the heart muscle, and other heart-related complications. So, unfortunately, it does impact older drugs as well as even newer drugs. But in these certain cancer treatments, in turn, they're associated to indicated tumor types, which do tend to lead to higher incidence of cardiotoxicity.
Forgive me, Dr. Wonsettler, but I have to ask, how do you square a cancer drug doing a good job when it's causing cardiotoxicity? How do you square the two? It's damaging the patient's heart.
Yeah, it's a good question. And they're effective at treating cancer. And when we think about our new medicine, so they're doing a good job at treating the cancer, especially when we think about how far we've come in the outcomes and survival rates of breast cancer across the years. It's quite miraculous. However, even in those newer therapies, even though they're targeted specifically for that tumor, we still want to focus our research in reducing that off-target damage. So continued opportunity to get even better and more focused, because why that medicine is ultimately trying to kill those cancer cells, we want to make sure that it's not damaging healthy tissue like our hearts as well. So it's certainly a fine balance there.
And also, is there any liver, are you seeing any liver toxicity with these drugs?
We do watch for toxicity all the way around. Certainly, yes, oncology treatments can cause other toxicities, and we do watch those through the guidelines, um, but certainly focused on cardiotoxicity as well.
Okay. Where do you see more incidents of cardiotoxicity? Accelerated approval drugs or the ones that follow the traditional approval pathway?
Yeah, because we really focus on those certain medicines, like I talked about when we think about anthracyclines, HER2s, immunotherapies. Those then in turn treat certain cancers, largely breast cancer. So patients treated with anthracyclines and HER2 inhibitors are at a higher risk of cardiotoxicity. And this is because these drugs are more common for this cancer type. Lymphomas, leukemias, these treatments for these cancers, they often involve higher doses of those anthracyclines. and cardiotoxic agents, which leads to a higher incidence of heart-related side effects. Radiation therapy, I just mentioned that one as well. So patients receiving radiation therapy, especially focused to the chest area, can be at an increased risk due to that potential damage of the heart and surrounding blood vessels. So those specific treatments are driving those cancer types that we're treating. Now, as far as accelerated approvals versus the ones that follow a traditional pathway,
Mhm.
cardiotoxicity is ultimately driven at the molecular level through drug-specific mechanisms of action. So examples of that include like oxidative stress. So those chemotherapy drugs, like those anthracyclines. To your question, we are ultimately doing a great job at effectively treating breast cancer, but they can also generate what are called reactive oxygen species that cause that oxidative damage to the heart cells. So that can lead to cell death, ultimately weakening that heart muscle. Inflammation is another one. So some of those cancer treatments triggering that inflammatory response can lead to damage of the heart tissue. For example, those checkpoint inhibitors can cause myocarditis and inflammation of the heart muscle. The third one I'll leave you with is certain drugs like trastuzumab can interfere with that cellular signaling pathways. Essentially, that is really important to drive cell survival and function of the heart, which can lead to those myopathies that we talked about, it making it harder for the heart to pump and ultimately leading to heart failure.
Hmm. Can you talk about the accelerated approval process and how it differs from the standard drug approval pathway? Does this accelerated process raise concerns about cardiotoxicity?
Hmm, absolutely. So when we think about how drugs get approved by the FDA, there are multiple pathways, if you will, of how drug applications can move through that approval process. So the FDA accelerated approval program, which is a certain pathway that can lead to an approval of a drug, allows for earlier approval of that drug compared to that standard drug approval pathway. Um, if it treats serious conditions and fills an unmet medical need. So the good news is those treatments can come to market faster, filling an unmet need for patients who have those diseases. However, these accelerated approval pathways are based upon what we call surrogate endpoints, and that is a marker that is really thought to predict clinical benefit. However, it's not a measure of clinical benefit itself. So that's a really important difference between the accelerated approval pathway and the standard FDA approval pathway. It is good news that the accelerated approval pathway still does require that confirmatory trial, like a standard drug approval, but it could be delayed or take many years to complete that confirmatory trial, ultimately leading to that standard approval. So, with that being said, does the accelerated approval process raise concerns? Um, Possibly, indirectly, we could think about that accelerated approval process and in the realm of cardiotoxicity, due to that initial approval based upon those surrogate endpoints rather than comprehensive clinical trial outcomes. So this could mean that potential cardiotoxic effects may not be fully understood at the time of that accelerated approval. And the reliance on those surrogate endpoints can ultimately lead to an approval with incomplete data on the long-term safety because it still needs to go through that confirmatory trial. So these are just some of the reasons why it's imperative that timely, ongoing monitoring, rigorous post-approval studies are happening, ensuring the safety of these drugs that are approved through that accelerated approval pathway.
Are there any measures taken to monitor patients for signs of cardiotoxicity, and how can clinicians work to manage risks?
Yes, absolutely. So there's an array of risk management strategies and monitoring measures in place today. Those things include imaging, ECGs, biomarker testing, clinical assessments of the patient. This is all monitoring that's done to help detect cardiotoxicity even before those symptoms appear. So at baseline, patients that are starting those anti-cancer therapies, they're assessed for cardiovascular risk factors. Think of things like, do we have high blood pressure, hypertension? Do we have diabetes or other pre-existing heart conditions? So that full picture is assessed before that patient starts their cancer journey. There are also certain drugs that are used to protect the heart during cancer treatment as well. Um, How can clinicians work to manage these risks? So there's a lot of ways. And when we think about pharmaceutical options
Mhm.
to manage these risks, we can think about there's options that we can do largely through dose adjustments. So we can reduce the dose of those drugs. There are times that we call them treatment cycles. So every 3 or 4 weeks, the patient comes back for another treatment of their anti-cancer regimen. So we can lengthen those times out to when the patient has more break in between those cycles, or even use alternative therapies that can help minimize heart damage as well. So converting to other therapies is an option. Outside of pharmaceuticals, of course, the patient can always help protect their heart with lifestyle modifications. So we think about encouraging patients to adopt heart healthy lifestyles, really sitting down with them, talking through healthy diets, the importance of exercise, of course, any smoking cessation, if that's applicable. These things can significantly reduce overall cardiovascular risk as well.
That sounds like that last one might be a bit of a challenge if the drug is making you exhausted, but that's another discussion for another day. In your experience, are patients aware or made aware of the potential cardiovascular side effects of their cancer treatments? Should they be made aware, and how, without scaring them away from treatment?
Mm, very good questions. So, so yes, patients are made aware. There are societal guidelines today to help assess and educate patients, making them aware on the potential cardiovascular side effects of treatment. And should they be made aware? I feel personally very strongly, yes, absolutely. They should be made aware, to your point, without scaring them, appropriately educated. Certainly been my experience, especially in oncology, that patients here really want to be informed, and they should. They should be at the center of that shared decision-making process. Um, so I think back to some of the studies around that. There's a survey conducted by the Association of Community Cancer Centers, which found that patients who are engaged in their care tend to have better health outcomes. So this really helps to highlight the importance of practice like shared decision making and patient education in improving that engagement. We also understand that patients who actively participate in shared decision making are more confident. They understand more about their treatment and the side effects, and they're more satisfied because they're involved with those treatment choices.
Are there any technologies or clinical strategies aimed at reducing the risk of cardiotoxicity in cancer patients?
Yes, absolutely. So we did talk about some of those imaging and biomarker blood tests to help aid in the early detection of cardiotoxicity. There's also things like wearable devices like our smartwatches and fitness trackers today that help monitor heart rate and even the rhythm that help inform us, patients themselves. Also, we should mention cardio oncologists too. So, cardio oncologists are cardiologists or oncologists who obtain more training outside of their primary specialty to manage patients just like this, who have heart disease and cancer. So, that collaboration between oncologists and cardiologists really ensure comprehensive care, making sure that we're monitoring patients throughout the entire treatment process and even afterwards.
Hmm. Okay. And what changes or improvements would you like to see to address the challenges of cardiotoxicity in oncology?
So, goodness, we could think about so many aspects to that. A few come to mind, and we can talk through those. We
Yes, please.
At the forefront of that, we always welcome focused, standardized, current evidence-based strategy through, our widely accepted guidelines for the prevention and management of cardiotoxicity. So to get more specific and think about a few things. So in drug development, there are cardioprotective agents out there. So the investment in the development of new drugs that can protect our hearts from cardiotoxic effects of cancer. An example of this are SGLT2 inhibitors, quite a mouthful, but actually, they're just a class of medication that treats diabetes and things like kidney disease today. They have shown promise in preventing cardiotoxicity.
Wow.
Yeah, let's talk about targeted therapies too. So, those are some of the treatments that can lead to, there's still some of that off-target effect on the heart leading to cardiotoxicity. So just more focus there in the evolution of these cancer therapies that really focus the minimization of that off-target effect, making sure that those drugs are going right to the tumor. And then combination therapies, the development of those for treatments that include the cardioprotective agent alongside that traditional cancer treatment to reduce the risk of heart damage. Clinical practice is another aspect. We talked about drug development. Clinical practice would probably be the second one that I'd put out there. So early detection and monitoring. So that's just implementation of routine use of imaging techniques, biomarkers to detect early signs of cardiotoxicity. This regular monitoring can help catch heart issues before patients even become aware or before they get to what we identified as severe. Personalized treatment plans, we can tailor cancer treatments based upon that patient's individual risk factors for cardiotoxicity. So this would include those things like drug dosages and schedule changes to minimize those damaging effects on the heart. And then the third would make me think about policy changes. So just development of guidelines, establishing those updated guidelines for the prevention, detection, and then ultimately management in cancer patients that are based upon the latest research and the best practices. And policies for patient education, ensuring that all patients are well informed in a very standardized way about these potential effects. So we certainly have come a long way in prevention and treatment, but there's always a need to get better and do more. There is a need for ongoing research to really clearly understand the mechanisms of these treatments, improve that early detection, and develop effective prevention and management strategies. This is where we really work across our specialties to help do our part to improve that care. I'm using cardiotoxicity as this example. We're able to connect and support that journey of cancer treatment, helping to ensure prevention and monitoring for cardiotoxicity throughout that entire treatment journey.
I worry about our most vulnerable cancer patients, marginalized patients, and I wonder if they have access to this level of scrutiny in their cancer care, because a lot of times they come to a diagnosis much later, and because they're underinsured or they have Medicaid, I don't know that they have access to this level of screening and scrutiny. In your experience, can you talk about that at all?
Oh, you're so right. Supporting health equity in the management of cardiotoxicity is crucial to ensure that all patients are receiving fair and effective treatment to healthcare, ensuring that we're providing equitable access to cardiovascular assessments and ongoing treatments to making sure that they have access and transportation, regardless of our race, our socioeconomic status, addressing these social determinants of health to access healthcare, education, support systems for those non-pharmacologic options that we had talked about in diet and exercise, doing what we can, even when we're fighting the good fight in cancer. All these things can absolutely help mitigate those disparities that we do have in clinical outcomes. When we think about like what are some of those disparities when we look at statistics in African American women, they're more likely to experience cardiotoxicity from cancer therapies, referring to a study that just upwards of 70% of patients had higher risk of cardiotoxicity following chemotherapy compared to Caucasian patients. This increased risk is particularly evident with treatments like we've talked about, those anthracyclines and HER2 therapies. So addressing these disparities requires all of us, a multifaceted approach to improving access to healthcare, making sure that we're able to get to our appointments, increasing the representation in clinical trials, ensuring that the representation across all those determinants are represented in clinical trials, and then continue to push forward on those targeted interventions that are supporting our underserved populations as well.
That was well said. Dr. Terra Wonsettler, thanks so much for your time today and your expertise in this important topic. Really appreciate talking to you today.
Absolutely. It was a pleasure to be with you, Tamara.